So thanks to Dr. Unni and the team from RIC who have done a wonderful job, and thank you for the kind invitation. So I think the context of this talk is best exemplified by this particular publication. See the year 1999, which told us that the treatment of BRVO may be beneficial from the process of collateral formation and new treatment methods aimed at accelerating the process of collateral maturation. Perhaps this publication actually creates confusion in our minds, or similar publications have created confusion, and that's why this topic, imaging collaterals in RVO, what is new. So we all know, and this is the traditional belief also, that collaterals are frequently observed sequelae after RVO, and the result is opening up of collateral channels originating from pre-existing capillary networks. Now, what drives collateral formation? If you ask that question, then it's basically hydrostatic pressure, volume overload, disruption or damage to the deep vascular complex, and to add to it, shear stress. Now, how does shear stress have a role here? Well, primarily because shear stress acts as an agonist of sphingosine 1-phosphate receptor, or the S1PR1, and this is something that actually produces nitric oxide, and which causes vasodilatation and collateral formation. But S1PR1 is not something that can on itself drive collateral formation. You have to have an occlusion in order to have collateral formations. So how do you identify collaterals? Well, when you have collaterals, when you talk about collaterals in the retina, these are tortuous venules that lie within the retina, often cross the horizontal raphe, and are commoner in BRVO, whereas discolored collaterals are commoner in CRVO or HRVO. They have a loopy and thick appearance and originate and remain within the disc margin. So how to best identify them? Well, FA and fundus biomicroscopy have been used traditionally for identification, but they provide at best a partial identification because deep capillaries and intraretinal communications are often not visualized. So OCTA here presents an opportunity to detect the collaterals in a much comprehensive and better way and precise way, and they are more commonly found in eyes with major BRVO or ischemic CRVO, patients with poorer baseline vision, presence of large areas of retinal hemorrhage at baseline, and large areas of capillary non-perfusion. So when do you expect to see collaterals? So if you're talking about animal studies, you can expect to see them in 3 to 5 days. Now these are young retinas, these are retinas not disturbed by hypertension or atherosclerosis, but if you talk about clinical cases, when do you expect to see them? Well, if you have the right equipment, if you have OCTA, then you can jolly well see them in the first visit, which might not be the day the BRVO or the CRVO has developed. But however, these are eyes that are prone to have atherosclerosis or coronary artery disease, and you tend to see these collaterals mature over time, and you might not see them in the first visit itself because of atherosclerosis. So what about maturity of collaterals? Well, the collaterals usually mature in BRVO in 6 to 24 months, but in CRVO, they may or may not increase or decrease in size. What about the location of collaterals? Well, previously we thought that these were mostly in the DCP or the deep capillary plexus, but newer studies have shown that they can be in the superficial and the intermediate capillary plexuses as well. The difference is that in the superficial and the intermediate capillary plexuses, if you find collaterals, these are mostly arteriovenous pattern, and if you find them in the deep capillary plexus, they will mostly be in the venovenous pattern. So retinal collaterals temporally can be found in temporal retina, temporal to the fovea, or nasal to the fovea. And why this is important is because if you have too many collaterals around the disc, they may be leaky, and they may be a good indicator of persistent macular edema. Now, question is why? Because many of them go on to develop microaneurysms, and more the microaneurysms or more leaky collaterals, more is the macular edema likely to be. What about effect of medications on collaterals? Well, practically, they have no effect on the collaterals. So finally, a couple of questions, vision and CRT. So vision, as far as BRVO is concerned, less likely to experience improvement of vision in patients who have collaterals or lots of them. In CRVO also, they are characterized by statistically significant worse final visual acuity if these patients have collaterals. So if you also have global, look into global collateral vessel extension, I'll just take 30 seconds. They are correlated with FAZ enlargement, but there is more to, vision than just collateral, collaterals being present. You can have foveal bulge, track lines, and so many other things as far as vision is concerned. What about CRT? In presence of collaterals, the CRT is thicker at baseline, and as a consequence, there's significantly, you find greater reduction of CRT. However, if you talk about are collaterals beneficial? Well, the half-baked idea was once collateral vessels form, retinal venous pressure and vascular permeability decreases and lead to spontaneous resolution of macular edema. However, if you look at some other articles, they go on to say that collateral vessel development did not promote resolution of macular edema in CRVO, and collateral vessel formation was associated with refractory macular edema in BRVO. So to conclude, collaterals may be a marker of more severe variant of RVO. Collateral channels are neither necessary nor sufficient for improved vision after retinal vein occlusion, and octa-detectable extension of collateral vessels may not correlate to blood flow volume and rate, so a more specific flow quantification might provide useful prognostic information. Thank you for your kind attention.
Yeah. Thank you, Dr. Debdulal, for that wonderful talk. So I would just like to go back 2 slides regarding are collaterals actually beneficial. So if we look at our traditional learning, at least in patients with CRVO who develop disc collaterals, so in those patients, usually the development of anterior segment complications like neovascularization of the iris and all is relatively less. So what does our panel think about it? So are they beneficial or not?
I think the jury's out. Conceptually, I think they are. What we'd love is some sort of proper oxygenation mapping to show when they form there's some sort of improvement. I'm just going to make a general point about, I'm not sure how much we've learned since I started about collaterals, because the concept is they're opening up of congenital channels. But if you look here, you're getting collaterals across the horizontal raphe, which in most eyes are developmentally come into 2 areas. So this, to me, conceptually looks like a form of functional neovascularization rather than an opening up of an old collateral. And that goes, again, with the optic disc concept. When you have meningioma compressing an optic nerve, you have an opening up of a functional collateral as a sentinel vessel. I'm not totally sure, but I've never had convincing arguments that they are opening up of old vessels. What do my other colleagues think?
No, I think just, if I may interrupt, that was a very interesting term that you used, functional neovascularization. So anytime we use the term neovascularization, there is an element of leakage or something that should be associated?
No. So, and I'll go back to, functional neovascularization is exactly what we said in our debates about stable type 1 neovascularization. You can have a non-leaking type 1 CNV that's functional neovascularization. And you could argue it's the same with collateral. So I was working for many years with a vascular biology group where the big plan was to develop functional new vessels or reperfusion in diabetes with an endothelial stem cell approach. So that's actually what you'd like to do, but it's very difficult, if not impossible.
To ask the panelists, so do you think it is, let's say, that impacts more visual function, having collaterals that are leaking in the fovea or having ischemia in the fovea? What do you think impacts more visual acuity?
I think the ischemia is what would impact it more. And I see these collaterals are predominantly in those which are severely ischemic. Yeah. Rather than, so I think the visual acuity that they're correlating with presence of collateral is primarily for the ischemia rather than the collateral. So I don't think collateral per se would be dangerous or is not good for the eye. I think that's the natural course of how the body responds to it. I think it's the ischemia which is driving the visual acuity results that have been seen.
So to go back to the provocative slide that collaterals formation being beneficial is a half-baked idea, and you gave a good example that the observation is if you have collaterals, you still have macular edema. But macular edema in vein occlusion CRVOs doesn't make a lot of sense. So we all thought in patients with extensive capillary peripheral non-perfusion, if you laser the peripheral retina, where we know from studies where you sample the vitreous, you reduce VEGF levels. So we know it reduces VEGF levels. It doesn't actually have any benefit on the macular edema, whereas injecting anti-VEGF does. So that makes no logical sense. I'm not totally sure that we understand the logic of vein occlusion and macular edema, so therefore I'm not totally sure with the argument that collaterals are not necessarily beneficial.
If I can offer a little bit of explanation
Sure.
here to Dr. Stella's question. So it's more like Hemant sir just mentioned, that it has more to do with ischemia, the vision part of it. And if you look at this statement, global collateral vessel extension correlates with FAZ enlargement. So you have more FAZ enlargement, and you have poorer vision. That's one. Now, if you look at this one, the next slide, that is, so you have collaterals, you have a bigger central macular thickness or central retinal thickness, and this is primarily, if you go back a couple of slides and look here, if you have, these collaterals, which are leaky, then you are likely to have, edema, macular edema. Now, macular edema, as we all know, like it's going to drive down the vision, and maybe that's how anti-VEGFs, have a role to play here. It basically temporarily drives down the macular edema and somehow raises the vision, but it's not like, it doesn't do away with collaterals, as has been mentioned.
I think Dr. Dinesh Talwar wants to make a point.
This slide, collaterals do not form in the upper temporal retina. The collaterals form on the along the the temporal aspect between the upper and the lower vessels. These are not collaterals. These are leaking vessels from BRVO. And collaterals in BRVO and collaterals in CRVO, they're two different things altogether. In BRVO, collaterals are a protective mechanism because they allow flow from the blocked area to the unblocked area. So it's not, and this is not a collateral.
I agree with you, sir, maybe, but this is a published article.
So just
unfortunately, I have become a little skeptical about published articles in the last few
given
months.
your published articles ourselves.
But I, at least in 35 years, I've never seen a collateral in the upper temporal area.
So talking about, you're saying that in a CRVO, the collateral could be helpful, but
no, will not be helpful.
Will not be helpful.
See, in CRVO, the entire vasculature is blocked. So what are the collaterals? Where are the collaterals forming? They are not really true collaterals. They are just vessels which have opened up. Those are tortuous vessels which have opened up in CRVO.
Okay, the disc collateral.
Yes, the disc collaterals. In BRVO, the collaterals are connecting the lower one of the temporal areas to the upper one, or the lower to the upper, or the upper to the lower one.
So we're assuming they're opening up. So why would, what's the physiologic response for you to develop a squiggly vessel on the optic disc that doesn't follow any other vessel? Just as a...
I'm sorry?
What would be the physiologic mechanism of you developing a wide-bore squiggly vessel on the optic disc? If it's opening up a collateral?
No, that will only happen in CRVO, and it's not opening up. It is the block. Actually, it's a block which is causing that thing with the back pressure to cause the vessel to become more and more tortuous on the disc. It's not a true collateral in that sense. You can't see. You see, unlike BRVO, where is the collateral going?
So that's part of something that's not fully understood. I don't think.
So you see, the collateral. If it was a collateral, it would be decongesting something. But here, now think of it the other way around. Let's assume there's a block. What will happen behind? It will form these squiggly vessels all over. It will look like those are tortuous vessels, but it's not a collateral. There's a difference between the two things.
So, okay, I'm just observationally, think of the patient who has a CRVO.
Yes.
2 years later, the CRVO resolves, your caliber of your veins goes back to normal, but the disc collateral is still wide-bored.
Always going to be there.
Why?
Yes, because that's an anatomic change that has occurred there. That will never go away, and it
But
doesn't.
if the blockage has been removed, why won't it change caliber and go back to normal?
Unlike a neovascularization, it doesn't leak. It just fills up over there.
But not all new, and that's a separate debate. Not all new vessels leak, as we discussed with type 1 TMDs.
Yes.
So I think it's a very debatable topic. So maybe Dr. Adnan can have a final talk, and then we can move on to the next. Any final comments, Dr. Adnan?
I think this is such a great topic. I think we could all carry on, because it actually points to how little we know about it.
Exactly. Okay. Thank you so much, Dr. Chakraborty.